So first, I congratulate you on your endurance. And second of all, I want to apologize. This is a 50-50 partnership with Dr. Lee Bidwell and myself. And unfortunately, the A team couldn't be here today, so you're left with me. So what we've been working on and through his corporation is developing a drug delivery system for pregnancy. And particularly our lead agents are for the management of preeclampsia. So we have this proprietary injectable biologic. It's called elastin-like polypeptide. It is based on the elastin sequence, but it is modified slightly, and it can also be tuned to different molecular weights. It's got a lot of advantages for administration of therapeutics, particularly small peptides. So because it is based on the elastin sequence, it's very non-immunogenic. You really can't make antibodies to it even if you try. It has no noticeable toxicity, even at extremely high doses. It's very easy to make. We can teach a high school kid to make grams of protein in an afternoon at essentially 99% purity. And we can really do a lot of things with it. It's a versatile delivery system. So we can attach small molecules to it. We can put tissue targeting peptides on it. We can use cell penetrating peptides if we want to go after intracellular targets, or we can leave it unmodified if we want it to circulate. So there's a lot of different things you can do here. And then depending on the molecular weight that you use, you can actually tune the half-life of whatever the attached therapeutic is. So we can do a lot of these sort of fine tuning. It's also bioavailable after subcutaneous administration, so you don't have to do intravenous administration. This is the kind of thing that you can send them home with a syringe with. And so our lead agent is for the management of preeclampsia. That's really where I came in. I'm the preeclampsia guy. Lee is the drug delivery guy. This is a very common syndrome of pregnancy, the most common obstetrical disorder actually, that's hallmarked by new onset hypertension, proteinuria. It can then develop into full-on eclampsia, which leads to grand mal seizures and potentially death. I'm going to show you the bottom part first. The part that I really want to stress is there's currently no effective therapeutic for this condition, despite the fact that it's going to affect about 1 out of 20 women that become pregnant in the United States. The only thing that they can do is tell you to go home and lay down, which doesn't really work. And they can give you some mag sulfate to try to do seizure prophylaxis, but other than that, there's no effective therapeutic. And because the only effective therapy is to deliver the baby, it's the leading cause of preterm births. So about 200,000 women a year. And because preterm birth is one of the major drivers of perinatal mortality, it's one of the major causes of perinatal and maternal and fetal morbidity and mortality. Currently, it's costing about $2.2 billion a year on the health system. And then a market analysis was done a couple of years ago now that found that the market size for therapeutics for preeclampsia is probably around $1 billion a year just in the United States. And I won't go into really the mechanism of preeclampsia other than tell you that really the big player in the field is a VEGF receptor, alternatively spliced protein, which is secreted and acts as a VEGF antagonist. This causes widespread maternal endothelial dysfunction. So the mother's blood vessels begin to malfunction. This is ultimately probably what's causing the seizures in the advanced cases. And that endothelial dysfunction is thought to drive these clinical signs of preeclampsia. I'll also mention that there's a big role for inflammation. There's a reason this used to be called septicemia of pregnancy. So we've got some therapeutics we have that target these pro-inflammatory cytokines. And so this is what we sort of went with as our lead agent. People had sort of suggested for years, well, if there's not enough VEGF signaling, why don't we just give VEGF back? The answer is that the half-life is 20 minutes. It's not druggable in its current form. And so what we did is we made a chimeric ELP VEGF fusion. This is actually several of these now. I'm going to show you the lead agent, which is based on a VEGF-A, but we have a number of these VEGF-derived peptides attached to ELP. And this is the point we really want to stress. When you start trying to develop drugs for pregnancy, the first complication and the thing that scares people off is you're going to cause teratogenicity, right? You're going to cause some sort of birth defect. What we did is we built an ELP that was with the correct charge and the correct molecular weight that it absolutely will not cross the placenta. We cannot detect any of our ELP-based therapeutics in the fetal circulation. And it's up to this point, we've managed to find no toxicity. And I told somebody this earlier, the running joke is if we ever attach ethanol to this, we probably could just print money, because we could just, it will not cross. So what we have here, this is from a rat. You can see that we've stained the placenta red, the fetus is in green. And with, or excuse me, the placenta is, the red signal is the ELP therapeutic with a fluorophore attached. And you can see that we get no translocation across to the fetus. And I'm not going to show you a lot of data today. If you're interested, you can look it up. This is published now. We have a rat preclinical model of preeclampsia, severe preeclampsia. It's one of the better models, I would argue, which is the reduced uterine perfusion pressure model in the rat. And we did indeed find that we got a dose-dependent decrease in maternal blood pressure. There was a lot of other outputs. We saw improvements in endothelial function, vascular function. So this therapeutic does appear to be useful in this preclinical model. We're also currently checking it out in a few other ones. As far as where we are, so we have several different agents. The ELP-VEGF was the lead agent. At this point, we've sort of completed the preclinical in vivo PK, efficacy, and tox in the rodents. We've actually given it in a porcine model for a different indication. We also saw no toxicity in the pigs. And starting in about 3 months, we have non-human primate experiments set up. So we're going to be doing pharmacokinetics and preclinical tox in the rhesus macaques with that agent. We have another ELP. This one's is being written up right now, or a VEGF family member, which is essentially we've got very good results in the rodent model. As soon as that's published up and gone, we're going to start trying to get funding to move that into the non-human primates. And then we have another one that's sort of a little bit earlier on in the in vitro optimization stage. We also do have several different anti-inflammatories that we made. One of those is published now, this first agent. This is actually an NF-kappa B inhibitor, which we used in the rodent RUP model and found that it was efficacious in that model that we could potentially start moving forward with. So this is sort of where we're at. Up to this point, we've actually secured a lot of funding, primarily from NIH and also some from American Heart Association, about $6.5 million to advance all of these different therapies through different stages of development. So with that, I kind of want to say, hey, I really still want to cure preeclampsia, but it's also a versatile model or a versatile system for administration of any agent, essentially, during pregnancy. And I will be happy to take any questions. Yes, ma'am.
Thank you. So you mentioned American Heart Association, which actually links into the question I have, which is we now know that preeclampsia is an independent risk factor for much later years, later stroke and high blood pressure. Is the mechanism of action persisting, do we think? And if so, could this also be a therapeutic for a subtype that is itself its own risk?
That's a good question, and it's one that no one really has the answer to. There's sort of two competing theories. One of those is that the preeclampsia is causing something that is increasing the risk factors later in life. The second theory, and I think probably the one I lean towards, is that pregnancy itself is the stress test, and that these women may have subclinical cardiovascular dysfunction prior to the pregnancy, and the stress on the cardiovascular system during gestation is really unmasking something that was there sort of all along. And so we don't have that answer. The answer is if it's something that the preeclampsia is actually causing, then yes, this potentially could be something that could improve long-term maternal outcomes. From our standpoint, the reason I originally got into this was, because they have to induce oftentimes these women prior to term, and these babies have low birth weight and they're in the NICU, that causes them tremendously high increased risk of cardiovascular dysfunction later in life. And so if we can just prolong the pregnancy long enough for them to get further along into the term, then we could potentially have really beneficial effects on the babies in their long-term cardiovascular health.
Anyone else? Well, thank you. So you couple it to you couple VEGF to ELP, And you said it increases the half-life of the VEGF.
Yes.
How long does it increase it to from about 20 minutes?
So with the VEGF, and it's dependent on each construct that we make. So, but with the VEGF, it's somewhere right around 20 hours. I'll also mention that we have some data that's not published with some of our second agent that we can do subcutaneous administration, and it actually creates a sub-Q reservoir that dissolves slowly over time, and we can get 2 weeks of therapeutic levels from a single dose. With that agent, we have a very druggable. The VEGF itself didn't behave that way, but the second line agent did. So,
Thank you very
my time
much.
is up.